and helpful.
Very good. Thank you, Sarah.
You're welcome. Do you want to go ahead and get started, Dr. Kennedy?
Yeah, why don't we get started? We may have a few more people come in as we go, but in the interest of everybody's time and respect for everybody's time, why don't we get started? So we want to welcome Dr. Elena Robinson, who's board certified in psychiatry and neurology, working at Cherry Hill in Swedish, and speaking on updates in migraine headaches. And I'll bet you're a Husky fan. It's just a wild guess.
Definitely.
Very, very trained at the University of Washington, and that was my medical school too. So nice to see alumni. So thank you for being with us today. And again, we'll probably have people joining as we go, and we have some material handouts here, and really appreciate it. So thank you.
Okay. Well, migraine, big topic, right? Big topic because of how many patients suffer from it. And if we could have a next slide, please, which I included to demonstrate just how long humans were describing this affliction that is so disabling and so prevalent as it happens. Migraine is the Greek word for hemicrania, although we know that it doesn't always involve just one side of the cranium or the head. And names dropping, that we can recognize who Julius Caesar was, or Darwin, or Marx, or Nobel. All of those fantastic people suffered from migraines. They in fact described them in either their poetry or their writings, or it actually affected their creativity. And if we go to the next slide, we can review what migraines are. The definition of American Headache Association means that it's a headache lasting anywhere from 4 hours to 72 hours. Initially, it was described as unilateral, but we see patients who have bilateral headaches very frequently, or the head pain switches sides. And in fact, that very fact that the headache switches sides is reassuring for the doctors, but can be troublesome for the patients. For the doctors, it means that structural lesion responsible for head pain is a lot less likely because it swaps the sides. And for the patients who are oftentimes suffer from migraines since childhood, any change is a concerning change. And I frequently discuss it with my patients. We know that migraine involves trigeminal pathways, although every headache, frankly, involves trigeminal pathways. Trigeminal nerve is enormous nerve that has intracranial component and neck component, which is important to remember because spinal trigeminal nuclei localized to the cervical distribution at C2, C3 is what commonly leads to occasional misdiagnosis of migraine as a cervical pain. When that nuclei is involved in migraine process, patients often have stiff neck and cervical pain. Whatever triggers migraine, and unfortunately there are so very many triggers, engages trigeminal pathway, and trigeminal nerve, apart from supplying everything from shoulders up, and by everything means teeth, every sinus we have, cover of the brain or dura. It's particularly heavily innervating posterior dura, as well as distribution periorbitally around the ears, inside of the ears. Every single part of our cranium is studied by trigeminal nerve endings. But it's important to remember that trigeminal nerve also supplies blood vessels. And the actual pain process comes from that very mechanism. Once the migraine is turned on, so to speak, blood vessels dilate extracranially and intracranially, leading to that sensation often described by our patients of pounding, throbbing, eye pressure, or some patients describe it as their eyes are about to pop out, and or a sensation of throbbing, pounding, pain at temples. And we also know that this vasodilation is associated with some inflammatory changes in the intima of a blood vessel, which sometimes is visible on brain MRI and referred to as migraine microangiopathy. That migraine microangiopathy on MRI looks like this little dots in the frontal and parietal distribution. So it's the sixth most disabling disease in the world, and that speaks volume. And whatever statistics one reads, it certainly involves a lot of persons, oftentimes in prime of their life. Children, certainly. More and more I hear from my patients that their first migraine experience, they remember clearly when they were 4 or 5 or 6. And obviously it's awful when a child can remember a painful experience so clearly in adulthood. And American Headache and American Migraine Association has a criteria for migraines, define it as 5 headaches attack over lifetime with typical symptoms, which we'll discuss those symptoms shortly, and no underlying cause being structural lesion or some other conditions. And there are rare vascular conditions that manifest as migraine, yet they have a stronger association with strokes and other neurological progressive conditions. There aren't any biological markers for migraines. It's a clinical diagnosis. I personally often have to convince myself that a headache is not a migraine. We know that it can be often associated with sensitivity to light, sensitivity to sound, sensitivity to smell, motion sickness, nausea, certainly, unfortunately, vomiting when the migraine is very severe. In pediatric patients, the sensitivity to light, smell, and sound is not as prevalent, and the headache lacks more prominent migraine features. It's a background headache that tends to be constantly present, but if you ask a teenager or younger child about whether they are light sensitive or sound sensitive, they're not likely to tell you that, although I'm certain that there is an exception to every rule. Migraine occurs equally in teenage boys and teenage girls. The ratio is 1-to-1. But as the hormonal changes occur, that ratio changes to 3-to-1. For every 3 women, there is a man who suffers from a migraine. And it has to do with several things, certainly estrogen related, certainly cycling related. When attack is untreated, it can last for 72 hours, but sometimes it can last for days, and we all know that. We all met patients whose migraines lasted for a week or longer, and they had to seek medical attention in emergency room. Other symptoms of migraines can be equally as disabling. If you can't tolerate light, so motion or sound or smell, or if you cognitively cannot function well, you certainly would be just as disabled. And we know that during migraine, some patients can think well or formulate words well. There are a lot of subtypes of migraine, some of which are associated with frank vertigo or persistent dizziness. And patients are precluded from normal functioning. Routine activity can significantly aggravate their symptoms. And exertional activity in particular, anything that is involving bending or lifting or Valsalva-like activity makes pain considerably worse. Nocturnal migraines or migraines that patients wake up with are actually most common. And there is a proposed mechanism for it. The mechanism being that our thalamus, that egg-like sensory structure, preparing us for a state of wakefulness. And as it does, as it ramps up brain activity, depending on obviously many things, so what happened in preceding day and or was patient exposed to trigger or triggers, that ramping up can go into state of migraine, and patient oftentimes already wakes up with a full-blown symptoms, which could be challenging to treat because, as you know, we always tell the patients to take their medication as soon as possible. And if I could have a next slide, please. Migraine does have stages. Prodromal stage of migraine is not always recognized by the patient, although I try to encourage a patient to look for some indication of prodromal state because most medications work better when you actually take it at that stage. Prodrome can mean that patient has unsuppressible yawning. All of a sudden they start to yawn and yawn. A person all of a sudden can feel extreme fatigue or have an incredible amount of energy. Some of my patients describe that if they feel that burst of energy, instead of being excited that they can accomplish a lot, they think, oh, it's coming. For some patients, while they recognize that something is off, they just don't feel right. They can't quite put their finger on what it is that's happening within that prodrome. Aura is a part of prodrome. And about 15% of patients have aura. Duration of aura is important. And we consider aura prolonged aura if it lasts more than 45 minutes. But of course, it's just a reference point. It does depend how complex aura is. It could be a shimmer or a blind spot that gets bigger and bigger and bigger. Patients can describe the vision as static. Some patients experience narrowing of their visual fields. And oftentimes, aura precedes the onset of actual migraine by about an hour or so, 30 minutes to an hour. That's common, but migraine doesn't necessarily follow the definition of American Headache Association. Every person suffers, unfortunately, their own symptoms and have their own triggers. Usually it's more than one trigger, which is why sometimes it's so difficult to interpret. If a person, for example, didn't have a perimenstrual period and the barometric pressure didn't change, maybe they wouldn't have had a migraine. But most triggers are additive, and once they add to what actually amounts to brain overstimulation, if you will, a brain goes into migrainous state, and that can last for a very long time. as I mentioned, not everyone suffers from aura, but presence of aura is significant. Migraine as a disorder is considered to be closer related to stroke disorders. In patients who have aura, especially if they have aura that's prolonged, that takes even more special significance. I always pursue specific diagnostic workup for my patients who have aura of any kind, sensory aura being one-sided tingling or visual aura. And the reason behind it is, as we know, in general population, presence of patent foramina valley is estimated to be 25%. And patent foramina valley, typically in general population, is small and not clinically significant. In patients with aura, that statistic changes to 50% and more clinically significant. And what I mean by that patent foramina valley size that gets rated 0, no PFO or cardiac shunt, to 5, which is a big shunt. In patients with patent foramina valley who have aura, that shunt is bigger and can become a stroke risk factor. So presence of aura is very significant. I always request diagnostic workup for patent foramina valley by either requesting echo with bubble study or vascular test called transcranial Doppler with bubble study. And if PFO presence or shunt presence is suspected, I will proceed with diagnostic workup that includes hypercoagulable screening. Going back to the stages of migraines, the headache itself can last for hours to days. And patients describe it in various ways. Pounding, throbbing, drilling are very common descriptors. And any structure from shoulders up can be involved. I have met some patients who literally would have a toothache and initially would be going through diagnostic workup involving their dentist. And yet later on it was established that for them it was manifestation of a migraine. And that's important to remember. The other common misdiagnosis comes from sinuses. All of our sinuses are lined by trigeminal nerve. And when the nerve is on, the sinuses tend to become somewhat inflamed and congested. And of course, that's where this confusion is coming from. Is it a migraine associated with sinus congestion, or it's a sinus process, and so on? And they feed off each other. Patients certainly can have sinusitis and develop a migraine. Or unfortunately, migraine persists long enough and it disrupts normal sinus drainage. It can put patient at risk of sinusitis. But it's worth careful consideration trying to see, does patient truly have sinus problem, or is it another clinical manifestation of a migraine? And then postdrome that also unfortunately can last for days. And patients often do describe it as a hangover. The headache itself is gone. Oftentimes during that stage, patients have allodynia, where they touch their hair or their skin or upper shoulders, and the gentle touch can actually trigger unpleasant sensation. And brushing their hair or wearing any jewelry triggers certain degree of discomfort. And this prodromal state often is associated with sensation of muscle ache, almost described as a flu-like symptom or symptoms. And certainly not disabling to the point where a patient can't function, but it makes it very difficult to function. And if we could just move to the next slide, please. I have already alluded to the fact that migraines are very common, and whatever statistic one reads, it usually quotes that about 38 million to 40 million of Americans suffer from migraines. And the percentage of population is quoted to be between 12 to 15%. That's a lot of patients. And even though women are more likely to experience migraines, we certainly treat a lot of men with severe disabling migraine conditions, because migraine triggers do not just involve hormonal triggers. And because our society now has this screen on time, essentially all the time. And that is one of the very prominent trigger where you have a visual task in one way or the other, and that visual task overexerts the brain, initial visual pathways, and essentially the brain. In 80% of patients who suffer migraines, we find typically multiple family members who suffer from migraines, and usually first-degree relatives. Most of migraine sufferers develop headaches between ages 15 and 55. But I do have patients who, as I mentioned, describe experiencing migraines as children. 70% of patients, men and women, will stop having migraines after age 55. For women, menopause plays a big role in that. But the perimenopause almost invariably destabilizes migraines, and fairly significant. In fact, so much so that if I meet a patient at a certain age group where I might think that they're approaching perimenopause and they're describing worsening symptoms, that is taken in account when we talk about treatment options, the causes of deterioration, the extent of diagnostic workup. Typically, if patients had specific presentation of their migraines all of their life, and unexplainably those presenting symptoms change, that already warrants consideration of additional diagnostic workup. And additional diagnostic workup depends on age group. Certainly at the age of 50 to 55, we tend to look for some autoimmune and rheumatological conditions and check SED rate. Not infrequently, we do repeat brain MRI imaging, because brain MRI imaging tells the story. It tells the story that CAT scan can never tell. For example, in patients who do have cardiac shunt or patent foraminal valley, we often see subcortical changes that couldn't be explained and don't look like migraine microangiopathy, and couldn't be explained by someone's somewhat elevated cholesterol, and that requires further diagnostic workup. So I based my diagnostic workup for cardiac shunt on patients presenting symptoms, but sometimes on appearance of brain MRI imaging, especially if subcortical white matter is involved. So unfortunately, not everyone postmenopausally has resolution of migraines. Some patients suffer from migraines lifelong. And the more complex presentation of migraine is, And what I mean by that, do patients have aura? Do they have cognitive involvement as part of their migraine? Do they have multiple family members suffering from migraines? The more likely, unfortunately, migraines to persist, because in some conditions, especially more complicated, rare migraines like hemiplegic migraines, where we identified several genetic factors, and we actually can screen the patients for hemiplegic migraines. That disorder sadly will persist the entire life, and perimenopause is not going to, or menopause, postmenopause is not going to lead to resolution of migraines. There are a lot of migraine triggers. The list of foods that can trigger migraines is much longer than the list of foods that doesn't. And of course, common culprits are stress. Who isn't stressed nowadays? Dehydration, hunger, overstimulation. Certain, but unfortunately few triggers can be controlled by a patient, like sleeping pattern. Barometric pressure changes certainly cannot be controlled by a patient, and that's oftentimes is a trigger for very many patients. I recently have met a patient who is 70 plus, and she told me something brilliant. She said that over the course of her life, she figured out that if she were a mushroom, she would be good, because she would live in a dark, moist, quiet place, and she wouldn't have any migraine. Migraine trigger involve change, any change from the routine. So it's tough to tell a younger patient that you have to live a very boring life. And the sameness is a key to prevention of migraines. That any change, be it change in weather pattern and certainly change in daily routine, can push the brain towards migraine. I list smoking as a migraine trigger. It's not just migraine trigger, it plays a big role in cluster headaches as well. And the reason behind it is because smoking precludes, especially medium-sized intracranial arteries, from being able to successfully rejuvenate, among other mechanisms that it actually promotes early aging and causes health problems. In cluster headaches, it's one of the more prominent risk factors. I wanted to mention cluster headaches because oftentimes we see this diagnosis of cluster migraine. The diagnosis doesn't exist. There is no such thing as a cluster migraine. Migraine headaches can recur and recur and recur, but the two types of headaches are very different. And they're initially recognized on how different they are by patient telling you their story. You can ask the question, during the headache, what do you need to do to lessen your suffering? Migraine sufferer will tell you they have to find dark, quiet place to diminish that overstimulation, to hopefully be able to drift to sleep. And sleeping actually resets the brain or reboots the brain computer, because it calms it down, and go, with some luck, it actually can normalize brain function. But a cluster headache sufferer will need to pace and distract themselves from pain. It's called suicidal headache because it's so intense and so painful that the patient has to do something to distract his brain or her brain. I said his because most cluster headache sufferers are men, to distract it away from that painful process, they would be pacing, and they would tell you that they have to do something, they have to move around, they have to try to focus on some other task away from this pain until obviously, hopefully, the treatment can help controlling it. And moving on to treatment options, we're very fortunate nowadays. If we could just change a slide, please. I mentioned triptans and the newer medications only because these are most common bulk of medications we use. But in fact, the first treatment for migraine existing centuries ago were ergots. Ergot fungus is present on spoiled wheat. And way before we had ergotamines as treatment, people figured out that if they eat spoiled wheat, they can help migraine. Unfortunately, since it wasn't a medication, it led to a lot of complications, particularly fingertips necrosis. And sometimes you can see it in art. You see people with this necrotic fingertips. Art historians will tell you that this reflects the fact that that was one of very few treatments for migraines. Ergots are still used. The most common representative of ergotamine is Migranol, or DHE, nasal spray. It's an excellent medication. It's long-acting, it works well. It does have somewhat challenging side effect profile, but nowadays it's very difficult to get an approval from any insurance. Whereas treatment with more common medications, triptans and calcitonin gene receptor peptide inhibitors, or CGRP inhibitors, has a pathways that patients meet going through treatment stages. In triptans, as I listed, there are 7 commonly used triptans. They're similar, but they're different. They're different in how they're administered, and they're different in frequency one can use it. 2 medications in the list, naratriptan and frovatriptan, have very long half-life. And that permits using those medications in certain circumstances for perimenstrual migraines as a preventative treatment. Patients can be put on naratriptan 2.5 milligrams twice a day and recommended to start it within 24 to 48 hours prior to usual perimenstrual migraine and continue on for up to 6 days. Because naratriptan half-life is so long, 18 hours, it would not cause a rebound headache, whereas sumatriptan would, rizatriptan would, elatriptan would. Frovatriptan is an excellent medication, also has very long half-life, but almost no insurance nowadays covers it. It's not entirely clear for me why, but invariably I see that it's not on formulary, and pre-authorization of medication is very challenging. Delivery of medication, a mode of delivery, is very important, because if patient has very prominent nausea, you want to bypass oral delivery, and you want to bypass oral delivery for more than one reason. During migraine, we don't absorb medication very well, and so mode of delivery that allows you to use intranasal spray or injectable medication or sublingual medication is preferred. It's faster, it's more reliable. Almatriptan is an excellent medication, but once again, for some reason, almost never is on formulary of any insurance company. And with triptans and CGRP inhibitors, we nowadays oftentimes combine them. In CGRP inhibitors, several medications are preventative. Preventative medications include Aimovig, Ajovy, Emgality, Qulipta, and Vyepti infusion. One of that list, a Nurtec, can be preventative and abortive. And that's a unique property. We don't have any other medication that works like that. CGRP inhibitors have excellent side effect profile. The first to be released in 2018 was Aimovig. And Aimovig can cause mild constipation. It's not an infrequent side effect, but relatively easy to remedy. You can ask your patient to take magnesium that helps migraine prevention and can help constipation as well. Ajovy and Emgality are both monthly injectable, although one can use 3 doses of both every 3 months. I personally think that when they inject it monthly, they're a little bit more effective than when they're injected once every 3 months. Qulipta is an oral medication. It's a very well tolerated medication. Most common side effect of that medication is mild weight loss. And typically that stabilizes after about a month. Some patients in the first couple of weeks described slight queasiness or not even so much nausea, just this awareness of having slightly unsettled stomach, I guess. Vyepti is one of the newest preventative treatment. It's an infusion treatment performed every 3 months. The infusion itself takes about 30 minutes. The setup and organizing the treatment probably amounts to about an hour of treatment duration. All of the preventative treatment bind to different subreceptors, which is why even if the patient did not respond to Ajovy injectable treatment, it doesn't mean that Emgality will not be effective, or certainly other medications on that list. Qulipta, out of all the preventative treatment, probably works faster than anything else. Most patients report some degree of improvement within first month. And the way patients tend to describe it is that the migraine is trying to come on and evolve and then dissipates. Remarkably, that in the past, we could achieve migraine control. And what I mean by that is using older medications that we borrowed from different disciplines, be it anti-seizure medications or beta blockers or antidepressant medications. We could decrease migraine frequency, intensity, and duration, but only with newer class of treatment, with CGRP inhibitors. We now had success of actually achieving a remission, where I have patients now who have been headaches free for a couple of years, which is obviously a remarkable treatment result. Patient can reclaim their life that is no longer dictated by migraines, where you tip-top around trying to, like on a minefield or something, trying to not to do something that can result in hours or days of suffering. And among other treatments, certainly worthwhile mentioning Nurtec, because we all have to deal with insurance companies. And the insurance companies dictate what we can or cannot do, and you have to take it in account whether you like it or not. The way to be able to get to CGRP inhibitors is for the patients to try 2 triptans. Nowadays, almost every insurance, if treatment trial, abortive treatment trial with any 2 triptans was either not tolerated or not successful, allows us to apply for CGRP inhibitor. And because Nurtec, which is ODT, orally disintegrating, can be used as abortive or preventative treatment, one can request it as abortive treatment. And once it's approved, the rest of the pathway towards newer medication class is a little easier. Because typically, if 8 tablets that are usually approved as abortive treatment are not effective, one could apply for a total of 16 tablets and interchange one regimen, which means taking Nurtec as abortive therapy at onset of migraine, to another regimen, which means taking Nurtec every other day as a preventative treatment. Nurtec half-life allows coverage for 48 hours, and within that 48 hours, even initially, migraine is not likely to recur. We do combine CGRP inhibitors with triptans. Their mechanism of action affects calcitonin gene receptor peptide, which is believed to be responsible for evolution of migraine. Triptans block production or synthesis of peptide, and CGRP inhibitors, as the name implies, inhibit the receptor for the peptide. So they actually can achieve synergistic clinical effect, and typically are well tolerated together. And if we could move to a next slide. There are patients who are not candidates for treatment with triptans. And quite a few patients are not. If somebody has history of cardiovascular disease, stroke, vasoactive medications such as ergotamines or triptans cannot be used safely. CGRP inhibitors can be used safely, but we know that migraines during pregnancy can deteriorate, and neither of those classes of medications are considered to be safe, nor they are approved. Nowadays, we have migraine treatment devices, and although some of them are relatively new, they present another option for our patients. 2 of the devices have been around longer and can be approved through some insurances. Cephaly, which is basically this sort of neurostimulator, or I should say neuromodulator, applied to the front of the cranium, no longer requires prescription. I offer patients prescription if they have Flex account and can be reimbursed for that. The cost of Cephaly device approaches $400. But let's say you have a patient who is pregnant, and in the first trimester, nothing can be safely used apart from riboflavin or B2 vitamin with magnesium, and occasionally very short burst of dexamethasone steroid to break the headache. Nothing is safe enough. Cephaly would be safe, and the company making the device has a program where patients can use it up to 3 months, and if it's not effective and it doesn't do the job it's claimed to be able to do, which is prevent migraines and abort migraines, the device can be returned and the sum of money that is paid for it will be reimbursed. Cephally is very easy to use. Um, there are two protocols. The protocol that aborts migraine is longer. Patients use it for 60 minutes. And there is a preventative protocol where patients have to use it every day for 20 minutes to prevent migraines. I have certainly met a lot of patients for whom that little device made a huge difference. It prevented migraines, it aborted migraines quite effectively. Like everything, nothing has worked for everyone, but it's a very good option. Nerevia, which is this, as you can see, the sort of arm device that goes around their arm, is approved for younger patients, 12 and older. And I have been successful in pre-authorization through several insurance companies. TRICARE, for example, definitely will approve it easily. It's a safe device. It does work fairly well, and again, could be an option for patients where medications are neither safe nor approved. Remaining 3 treatments are still, well, first of all, they're very expensive, and the jury is still out just how helpful they are. For example, the single pulse transcranial magnetic stimulation, or e-neura, which you applied in an occipital distribution, at least in clinical trials, was very promising. But its affordability precludes most patients from using it. The idea of it is very promising, and in fact, similar device is used by psychiatrists for a treatment of OCD as well as depression. And I recently spoke to one of my colleagues who had the same experience with the device, where it's quite promising. Patients in trials who use it really had some measure of success, but unfortunately, it's very, very expensive. Hopefully, eventually, I'm not sure when eventually is, when the cost comes down, it will be yet another option for patients who are not candidates for treatment with medications. And, you know, field of migraine treatment is now very busy with a lot of research and new medications. For example, 7 months ago, the new abortive treatment, nasal medication called Zavspread, was released by Pfizer company that makes Nurtec. And although it only has been around for 7 months, medication is very fast acting. It's an intranasal spray. It gets absorbed quickly. And in a lot of patients, the pain relief comes within 15 minutes, which is the shortest duration of therapeutic benefit we have ever had. So here we are with these treatment options. I have to mention Botox, of course. Botox has been around as a preventative treatment for, close to 20 years. But the trouble with Botox, while I find it to be very effective, patient has to go through treatment with 3 different classes of older preventative medications, which mean trying anti-seizure medication, antidepressant therapy, such as tricyclics or something else, beta blockers or some other alternative treatment, and also trying at least 2 triptans or 1 triptan and 1 ergotamine before we can submit the application for Botox approval. And also FDA approved Botox for migraine sufferers who have migraines for at least 15 days a month, which is obviously affects patient selection, and having migraines for 15 days a month is a horrible thing. So sometimes patients get referred to us and then they're saying, can they qualify for Botox? And I have to tell them, fortunately, you're not there, and hopefully you never will be there to need it. We'll be glad to answer any questions if you have questions or concerns. And, there are a lot of things that could be discussed within the scope of migraines, but this is kind of an introduction to what are most common treatments we currently use in our clinic.
Thank you so much, Dr. Robinson.
Certainly.
Does anybody have any questions?
While people are thinking about it, I'll ask, this is Scott Kennedy, I'll ask a question to Dr. Robinson. Thank you for this excellent presentation and update. This is a total change from what I learned long ago. So you mentioned, I think you mentioned that there was a familial hemiplegic migraine connection between family members that you might think about. Is there also a familial connection with patent foramen ovale or with aura, the phenomena of aura?
We see it running in families, yes, but there is no genetic testing available yet. And given that patent foramen ovale is fairly common, right? Because so PFO is present there in utero when child is developing. When child is born and takes a first breath, in 75% of persons, the PFO is closed. And 25% of people walking around, or every fourth person, there is a small, tiny hole in the heart that tends to be clinically, hopefully not significant because it's so small, right? But in migraineurs with aura, that changes. That statistic changes to 50% and a bigger hole. And unfortunately, there isn't, clinically speaking, it's a new sort of evolving field. For example, there is a trial that's about to take place, and that trial, once again, will look into whether closing patent foramen ovale for migraine sufferers, not from stroke prevention angle, but for migraine sufferers, preventing intractable headaches, could make sense. Because patent foramen ovale actually does play a role in triggering migraines. And here's how. The right side of the heart receives deoxygenated blood flow that has a lot of metabolic byproducts, for lack of better term. Those metabolites are usually cleared through lungs. But if there is a PFL presence or shunt present, and the mix is possible between right and left side of the heart, and that mix can be possible even when we have bowel movement or sneeze or cough, because ordinarily the pressures on the left are higher than on the right, but they can equalize when we Valsalva, right? When that mixing occurs and brain sees the metabolic byproducts it's not supposed to see, it triggers migraine. And that's why the initial concern even was taken into consideration, why some patients and why migraine sufferers with aura are more likely to have this PFO. Several research studies arrived to that eventually. But we're kind of in no man's land now. We know that presence of patent foramen ovale makes migraines worse, but we don't have a next step because previous studies have not proven that closing PFO makes migraines better, which is why in the next several months there will be another study which will involve 150 patients trying to address the same issue. I'm a big proponent of PFO closure because unfortunately I've seen my very own patients who had complicated migraines eventually suffering from a stroke because they accumulated more and more stroke risk factors. I hope I answered your question.
Yeah, thank you very much.
Certainly.
Any other questions? Yeah, I have one other, if I could, and that is, at what age do you consider the CGRP inhibitors? Consider using them?
I'm sorry, I couldn't hear you. Sorry.
Oh, my question was, at what age do you begin considering using CGRP inhibitors as part of the therapy?
Unfortunately, they're not approved for patients who are younger than 18. I don't see why they wouldn't be used, but they're not approved, and that makes it challenging. Very few treatments are approved for younger patients. For example, that Norevio is approved for patients 12 and older. So it's very tough to be a pediatric neurologist or family doctor or internal medicine doctor in treating younger patients because there are so few options.
Thank you very much.
Certainly.
Any other questions before we close out? Okay, well, hearing none, Dr. Robinson, thank you very much. This is truly an excellent update for migraines. Thank you for the work you're doing and for your availability for this presentation. Okay, well, have a great day.
You too. Bye-bye.
Bye, everyone.
Thank you everyone for joining. And our next CME will be with Dr. Chris Dale, medicine and AI, and the new update in EPIC regarding AI. Thank you.
Thank you.